Welcome to the deep dive. In the intensive care unit, our natural instinct as specialists, it's often to meticulously normalize every single physiological parameter. We're really trained to intervene, right,
hmm
to fix things. But what if that pursuit of perfect numbers sometimes causes more harm than good? What if, maybe surprisingly, deliberately allowing certain deviations, this concept called permissive strategies is actually, well, better care for our patients? So today we're doing a fascinating deep dive into a really crucial review paper. It's called Permissive Strategies in Intensive Care Units, Actual Trends by Domi and colleagues. This paper, it really makes you rethink what optimal care looks like.
That's exactly it. Permissive strategies in the ICU, PSACU for short, they're about intentionally allowing certain physiological parameters to drift a bit from those traditionally really strict targets. The core idea, fundamentally, is to mitigate the risks that come with being, well, maybe too aggressive with interventions. We're recognizing that sticking rigidly to normal ranges can, kind of surprisingly, lead to iatrogenic complications.
You mean harm caused by our treatments themselves?
Precisely. Or it can even worsen the patient's underlying condition.
Okay, let's unpack this. It sounds a bit counterintuitive, doesn't it, compared to how many of us were trained initially. So what's really driving this shift in critical care thinking? Why now?
Well, the shift is coming from a growing understanding, I think, that every single intervention has a cost, a downside. We're moving more towards minimizing those treatment side effects while still, addressing the patient's main problem. It really emphasizes highly individualized care, thoughtful clinical judgment, and applying guidelines maybe more flexibly. It's this realization that sometimes, less is genuinely more. The body's own compensatory mechanisms might actually be better left undisturbed, within certain bounds, of course.
That makes a lot of sense, actually,
hmm
especially when you think about the pressure we sometimes feel to hit those specific numbers, those targets. So let's talk about maybe the most prominent example, permissive hypotension. For you listening, this generally means aiming for a systolic blood pressure, maybe around 90 millimilli Hg, or a mean arterial pressure, the MAMP, of about 50 millimilli Hg. Often this comes up during initial fluid resuscitation and trauma.
Right. And the advantages here are pretty significant. It means giving less overall fluid, which helps cut down on risks like tissue swelling, interstitial edema, or electrolyte disturbances, hyperchloremic acidosis. And crucially, it also reduces the need for high-dose vasopressors. And those can have some pretty nasty side effects, think peripheral tissue ischemia or dangerous tachyarrhythmias.
Yeah, and this is where the evidence gets really compelling, isn't it? I remember seeing studies like the meta-analysis by Owat and Manichik and colleagues. They found that this kind of less aggressive hypotensive resuscitation in trauma patients actually led to better outcomes. We're talking reduced ARDS, less multiple organ dysfunction.
Exactly, though they did note a non-significant trend towards more acute kidney injury, which is something to watch.
True, true. And then there was that big National Heart, Lung, and Blood Institute trial, the one in sepsis-induced hypotension. It showed, interestingly, no statistically significant differences in 90-day mortality between the conservative and the more liberal fluid groups.
Right. And Maheshwari et al., in their retrospective study, sort of highlighted the dangers at both ends. They found that maintaining a higher MAP, like 85 millibillion Hg, was linked to increased risks, cardiac complications, AKI. But also, letting the MAP drop below 65 millimilli Hg was associated with higher mortality in AKI. It really shows that both overtreatment and undertreatment can be harmful.
It's a tightrope.
It absolutely is. The rationale, though, is becoming clearer. Fluids are drugs. They have side effects. Giving fluids too aggressively can quickly lead to fluid overload, this fluid accumulation syndrome, and that significantly bumps up mortality and ICU complications like, prolonged mechanical ventilation.
So if we're talking about tolerating lower blood pressure, does this whole permissive concept extend to other parameters, things we usually tightly control? What about, say, permissive hypertension?
Absolutely. That's a key strategy, for instance, in acute ischemic stroke. There, you might actually allow blood pressure to run a bit higher within AHA guidelines, of
Yeah.
course, like maybe below 220, 120 millim Hg if there's no thrombolysis, or under 1 ohms valves and 1 agate if there is. The idea is to ensure enough blood flow, enough perfusion to the brain tissue that's struggling. Avoiding hypotension there is absolutely critical to prevent making the ischemic damage worse.
Okay. And permissive hypoxemia, tolerating slightly lower oxygen levels. I feel like I've seen this in practice, especially with ARDS patients, maybe COPD too, trying to avoid oxygen toxicity.
Yes, exactly. Allowing maybe a PO2 between 55 and 80 millimilli Hg, or in SpO2 between, say, 88 and 92%. Studies have generally found no increased mortality with these lower oxygenation targets. It's about finding that sweet spot, avoiding the harm from too much oxygen.
And hypercapnia, permissive hypercapnia.
Ah, yes. That's become pretty much a cornerstone of lung protective ventilation, hasn't it? Especially in ARDS, and we saw a lot with COVID-19. We accept higher CO2 levels, sometimes up to 60, 80 millimilli Hg, maybe letting the pH drift down to around 7.20. The trade-off is minimizing ventilator-induced lung injury, and studies show this strategy really contributes significantly to improved mortality in ARDS.
Right. And finally, briefly, what about permissive oliguria, tolerating reduced urine output?
Yeah, that's another area where thinking is evolving. Recent studies are suggesting that maybe lower thresholds, perhaps down to 0.3 millimole uric acid, might be acceptable in certain contexts. The key takeaway here, I think, is that just seeing low urine output doesn't automatically mean the kidneys are failing or the patient needs fluid. What's really crucial is assessing fluid responsiveness before just giving a fluid bolus. We need to avoid that unnecessary fluid overload and all the problems it can cause.
So wrapping this up, what does all this mean for us, for specialists like anesthesiologists, intensivists, facing these decisions every day at the bedside?
Well, it really means that critical care thinking, true clinical judgment, is absolutely paramount. It demands this really delicate balance. You've got the evidence-based guidelines on one hand, but then you need your own clinical assessment and truly personalized care for that specific patient in front of you. We're constantly being reminded, I think, that jumping in too early or being overly aggressive with interventions, it can often lead to more harm than good. These permissive strategies really push us to think differently, more cautiously sometimes.
Yeah, this whole deep dive, it really highlights how our understanding of what's optimal is changing, isn't it? It's constantly evolving. So maybe the final thought for you to consider is this. How will these evolving permissive strategies continue to shape our approach? How will they further push us as clinicians to tailor management for each individual patient in the ICU, moving beyond those traditional, sometimes rigid thresholds towards genuinely better outcomes?